Good afternoon, everybody, and welcome to today's Medicaid Sustainability Initiatives and the Impact on Providers webinar. Before we begin, I would ask for our Spanish interpreter to introduce this service today.
Buenas tardes, mi nombre es Julieta y brindaré servicios de interpretación en español. En un momento este servicio estará activado. Para escuchar la interpretación en vivo en español del evento de hoy, seleccione el módulo Interpretaciones en la barra de herramientas de Zoom y luego seleccione Español. Tendrá la opción de seleccionar Silenciar audio original si desea solo escuchar el español. Este módulo de interpretación se activará momentáneamente.
All right, thank you very much. Next slide, please. All right, just a couple of housekeeping notes. Please note that we're recording the session today, and this will be posted on our website, so this can be used as a reference. As you have heard, we have Spanish language interpretation available. You can find that in the bar in your Zoom bar below. We also have closed captioning, and we've got more information on the website. We'll put in the link and our form if you'd like to submit questions. Next slide, please. All right, well, thank you for everyone joining today. We will be covering the spring sustainability actions in that timeline, what those actions actually are, and then we will have time for some questions and provide some resources. Before we begin, though, I would like to cover a few housekeeping items. This is a webinar focused on provider agencies. This will provide information to providers on the sustainability actions that HCPF is taking and what provider agencies need to do in order to prepare. While this is a webinar focused on providers, all folks are welcome. However, as noted, the information will be catered to providers, not case managers, members, or their family members. This is an opportunity for providers to learn about these initiatives, not to discuss concerns or disagreement with the various policies. We're hoping to hear from providers today if there are any additional information they need or operational guidance that is missing. I would also like to note that all case managers in the state have received extensive training just last week on these initiatives and how they plan to operationalize these changes. They have operational guides, they have had that training, and they have continued office hours to ensure they understand these changes. Lastly, I want to note that the question and answer pod is being monitored, but we will not be responding directly to each question or comment. I will pause after each initiative to speak to some of the questions that we're seeing in the Q&A. Your questions and comments in that forum will also be used to develop an FAQ. All right, so let's begin. Next slide, please. I'd like to start off by thanking you all again for being with us today. It's important to understand why these changes are needed. Before we get into the details of the policy and rate changes, I want to start by naming something directly. This is a really heavy topic. Anytime we talk about reductions or tighter controls, it can feel personal, and it is. These decisions affect real people, members, families, caregivers, providers, and communities at large. I want to acknowledge that up front. If you're coming into this webinar today with concerns, frustration, or any type of uncertainty, you're not alone. But at the same time, it's important that we're clear about the purpose of these changes. The core reason is simple, even if the situation is complex. We're making these changes because we have to protect the long-term sustainability of Medicaid's long-term services and supports in Colorado. So services remain available, not just this year, but 5, 10, and even 20 years from now. Next slide, please. As many of you know, Medicaid consumes more than 1/3 of our state's budget. This year, our state has experienced limited revenue growth from TABOR and other fiscal constraints. On top of that, we've been facing new federal policy changes, like H.R. 1, that are increasing the state's financial obligation. With that, the state faces a structural budget deficit. Without action, Medicaid and long-term services and supports, costs specifically, will outpace revenues, meaning that if we don't take action, nearly every single new general fund dollar will need to be dedicated to Medicaid, leaving no funds for other state funding obligations. So we have to take action to ensure that our program spend aligns with funding we have available. One statistic you'll often hear is that long-term services and supports population serves just 5% of the Medicaid population, but consumes 42% of the overall spending, and that's pretty standard across the nation. Serving people with disabilities and older adults are what Medicaid programs are designed to do, and appropriately so. These services are expensive, though. However, this creates perhaps a disproportionate responsibility to make sure that LTSS programs fit within our funding and are available now and in the future. Next slide, please. When we look at our home and community-based service waiver programs, we can see that there's significant growth in enrollment. For example, there's growing enrollment and an increased demand among children and older adults. The state also anticipates future increased enrollment with the rapidly growing aging population in Colorado. Then, once members are enrolled in these programs, they're utilizing significantly more services than they have in the past. So, what we know is that without changes, LTSS spending will exceed available funding. The sooner that we can address unsustainable trends, the less deep of reductions we will need to make in the future. Workforce shortages, increasing wages, all have significantly raised the cost of delivering care. So now we're in the position of needing to adjust our policies to align with these rising costs. As we go through this webinar today, I ask you to keep two things in mind. These changes are about sustainability and long-term access, not just short-term savings. Providers play a vital role in implementing these changes and ensuring continuity of care. With that foundation, I'd like to walk through some of the solutions and supports for what's changing and what it means for you as a provider. Because of the cost drivers, HCPF is implementing several components of solutions and support that start at the authorization of services. First, HCPF is implementing caps on personal care, homemaker, health maintenance activities, and community connector services. Case managers are also going to be utilizing the new direct care service calculator for justification and documentation of service authorizations for personal care, homemaker, and health maintenance activities. Case managers will also be required to collect health maintenance activity documents and support for authorizing HMA services. CMs will also utilize task standards for effective authorization of services. These are set times for each task. Some tasks are 0 if the task is not age appropriate. We also will be aligning the individual residential and service support rate. This will create equity and appropriate rate methodology for the services being provided. These things together will ensure that we can maintain the availability of these services across populations, ensure cost savings, and effective authorization of services. Now, I know you're all kind of thinking about when this will be implemented, and I'd like to go over the timeline on the next slide. Beginning April 1st of 2026, lots of things are happening. First, we have the annual unit limits being applied for personal care, homemaker, health maintenance activities. Additionally, for Community Connector, service is no longer available to children under the age of 6. And we're also updating the annual unit limits being applied. Lastly, we're also categorizing and implementing the new IRSS setting categories of staffed home versus shared living environment. Now, not all of these things will take place on April 1st for all of these members. This is taking place at a staggered timeline between April 1st and November 30th. All members must have their person-centered support plans and their prior authorizations revised or looked at and gone over with the member by that November 30th, 2026 deadline. Next slide, please. All right, we're going to cover some things that are very hot topics of age-appropriate guidelines. Next slide, please. Case managers are going to be authorizing services based on the age-appropriate task standards. What this means is that times for tasks that are not age-appropriate will not be authorized. Time will only be authorized when the care is extraordinary. Extraordinary care is a standard that applies across all direct care services. When a service is provided by a family member, it must meet the definition of extraordinary care, regardless of the specific service type. The key consideration is whether the care exceeds what a family member would ordinarily provide to a person of the same age and developmental milestones without a disability or chronic illness, and whether it is necessary to ensure the member's health and welfare and prevent institutionalization. Extraordinary care applies when the care exceeds what the family member would typically provide, when it ensures the health and welfare of the member, when it helps prevent institutionalization, and the care meets the service definition and documentation requirements. A couple of examples here. Parents providing skilled medical support for a child. A parent provides daily tube feeding, suctioning, and seizure monitoring for a 6-year-old child with complex medical needs. These tasks exceed what a parent would ordinarily provide to a child of the same age without a disability and are necessary to maintain the child's health and prevent hospitalization. Because the service exceeds typical parental care and is medically necessary, this meets the definition of extraordinary care and may be authorized when provided by a family member. Another example is a sibling acting as a primary caregiver. An adult sibling provides daily assistance with mobility, medication management, and frequent monitoring for an adult with an intellectual disability and significant medical needs. The level of care exceeds typical familial support and is essential to prevent institutionalization. This service meets the definition of extraordinary care and may be authorized when provided by a family member. Next slide, please. So with that in mind, let's go into a little bit more detail about the first set of CAPs, which is for personal care, homemaker, and health maintenance activities. Next slide, please. This chart shows you a high-level display of the 3 CAPs for these services. It has the annual unit limits and how that translates into approximate daily hours. Any authorizations above these limits require department approval, and case managers will complete that process. There are additional lower level approvals that are required at the specific task level. Providers should know that case managers must complete these processes before they will be able to provide an authorized prior authorization request to the provider. Next slide, please. Okay, specifically personal care. Personal care services are a covered benefit available to members enrolled in Community First Choice, designed to help members with daily tasks that they're unable to do. So, thinking about some of those tasks, that includes personal hygiene, eating, walking, transferring, positioning, those type of things. Services may also include a caregiver going grocery shopping, going with a member to an appointment to help with personal care services, and protective oversight for certain supervision needs. Next slide. Protective oversight within personal care. This one is has been highly utilized, especially since the service has been available to children since the implementation of Community First Choice. And we have had to tighten our regulations since December to provide a little more context and definition of what this means and how it can be utilized. So we're reviewing this today because we now have this clear and more defined definition, and there's a new limit. Protective oversight means providing active line of sight supervision requiring immediate intervention to prevent harm when a member's disability, memory, or cognitive functioning related behaviors or impairment place the member, others, or property at risk. Protective oversight shall not include restrictive practices unless a documented rights modification is in place prior to the provision of services. Protective oversight is only a personal care task and cannot be authorized as health maintenance activities. Protective oversight within personal care includes that intervention time, including but not limited to verbal redirection, blocking access to hazards, removing dangerous items, or hands-on guidance. Protective oversight shall only be approved when there is a documented evidence of risks requiring regular and predictable intervention within the last year. The member service plan must include the frequency, scope, and duration of the intervention required. Protective oversight shall not be authorized for purposes of companionship, childcare, general supervision, reassurance, emergency or crisis intervention, or routine monitoring that's not necessary to address a disability-related safety risk. Protective oversight alone cannot be the sole reason for the visit or service. Next slide. Specifically, when we're talking about kids, for children under age 18, protective oversight may be authorized only when the level of supervision requiring intervention is substantially greater than what is typical for a child of the same age without disabilities. Protective oversight cannot be authorized, again, for that routine childcare, typical parental monitoring or supervision that is age appropriate and expected for children of the same age. Here's a couple of examples for kids under 18. A 12-year-old child with an intellectual disability and epilepsy engages in frequent self-injurious behaviors, i.e., they have headbanging, triggered by sensory overload. These behaviors occur daily and require immediate intervention to prevent injury. Another example is an 11-year-old child with significant emotional and cognitive impairments that has frequent, unpredictable, aggressive outbursts that include hitting, biting, or throwing objects at others. Line of sight supervision is required to intervene quickly and prevent harm to the child, siblings, or caregivers. These examples are for when protective oversight might be authorized for a member, but not in lieu of other necessary services like behavioral support. Next slide, please. Homemaker services. Homemaker services are general household activities provided in the home of an eligible member to maintain a healthy and safe environment for a member. Some of those tasks include routine light housekeeping, vacuuming, cleaning bathrooms, kitchens, and bedrooms. Homemaker services must be completed within the permanent living space, except for the cases of acquisition, maintenance, and enhancement of skills, AME. It can also include laundry and shopping. This service shall be for the benefit of the Medicaid member and not for the benefit of other persons living in the home. Next slide, please. So, when we're talking about homemaker, we often have the legally responsible person providing that service. A legally responsible person means any person who has legal responsibility to care for another person. For children, this includes the parent or legal guardian of a minor child. For adults, this is limited to the member's spouse, either by marriage or common law. We get that question a lot. And it does not include the parent or legal guardian of an adult. We've got, right now, we've got to make sure that LRP hours are part of the total homemaker hours, not in addition to. LRP does not include hours authorized for extraordinary cleaning, which is offered through the Children's Extensive Supports and Supported Living Services waivers only. Next slide. So the new annual limit on homemaker, as noted before, is 4,500 units, which translates to about 3 hours a day. There's also a new limit of legally responsible persons hours for homemaker, and that's 5 hours a week, down from 10 hours. There is a limit of 2 LRPs that can be paid caregivers for a single member. Even if they have more than 2 LRPs, only 2 can be paid homemaking hours. So you could have 2 parents that each get 5 hours, but they can only total that 10. No more than 10 can be authorized. They can have more additional homemaker hours, but not those LRP hours. These new limits align policy when we look at other Medicaid programs, where there's often a cap on caregiving hours. This is a quality-focused action as well as a sustainability action. Please note that there's no exception to individual LRPs going above that 5-hour cap. If a member has 2 LRPs providing homemaker, they can each do that 5 hours. And the DCSC, the Direct Care Service Calculator, will outline the number of hours being provided. However, they cannot each go over. There's no exception to that 5-hour limit. Homemaker hours are inclusive of the LRP, not in addition to. Let's take this as an opportunity and pause for questions if there are any questions about the caps so far.
Yeah, we do have a few questions that have come in, and then we can probably refer to some questions that were asked yesterday too, because I'm sure that the group has probably some similar questions, just might not have thought to ask yet.
Yep.
So I think some of the beginning ones are how have case managers been trained to use the new direct care services calculator, and how should providers work best with the case managers to get correct PARs?
Great question. So case managers have been trained on how the task standards apply, what it means to use them, how age-appropriate guidelines and ages are built into that direct care service calculator. So they have received extensive training on that. As it pertains to a provider, I think, as you know, the case manager is the one that works with the member to complete that information and provide the rationale for those times, but they can absolutely support the providers can absolutely support a member in that process and participate in the support planning process if the member desires.
Thank you. Right, I see the slides are back up. Do you want to keep going through the slides or keep going through questions?
Let's go ahead and go to the slides and then we can pause again.
Okay.
Kelly, next slide, please. All right, health maintenance activities. These are skilled, routine, and repetitive health-related tasks furnished to members in the community or in their home. These services must be necessary for health and normal bodily functioning that a person with a disability is unable to physically carry out. This service is available through Community First Choice. Providers, please note that in order to provide health maintenance activities, you must be a licensed Class A or Class B home care agency and certified to provide IHSS. As of December 22nd, 2025, case managers are authorizing health maintenance activities using the Direct Care Services Calculator, the DCSE, and the HMA Documentation Guide to support determining when a service is skilled and how to document it. They're no longer utilizing the nurse assessor process to determine those hours. Next slide, please. HCPF has also identified frequent gaps in required HMA documentation. Missing or outdated documents limits a case manager's ability to verify skilled care needs and authorize services appropriately within the person-centered support plan. To address these issues, HCPF has developed a new HMA member checklist and an updated CFC HMA documentation guide. Members self-directing their services through CDOS or IHSS must now provide supporting medical documentation for HMA tasks to their case manager in preparation for their level of care screen or CSR. Case managers must collect and retain this information in the member's record. The HMA member checklist should be provided to members in anticipation of their assessment. This checklist outlines the kind of medical documentation that will be required and from whom it can be received from. These are not self-reported diagnosis, medical documentation dated, and it's from a medical professional. Documentation must be current within the last 1 year for children and 3 years for adults. Members and case managers are using the documentation guide and documentation checklist as part of the intake, enrollment, and person-centered support planning process. These tools are intended to strengthen consistency, accuracy, and transparency across assessments and authorizations statewide. In the event that an HMA task cannot be supported by recent or relevant documentation, it cannot be approved as HMA. However, the task may be approved as personal care, if applicable. Providers, please note that if a member asks for help with documentation, agencies can support this. However, the documentation must be medical and clinical in nature. All right, timeline. This is effective immediately. For new members without previously authorized HMA, they're going to need to provide that documentation before services are authorized. For members with current services, their services remain valid until the last day of the certification period. If they need new services or a revision, they would need to supply that documentation during the revision process. Next slide, please. All right, what you need to know. First, any exception request submitted is from the case manager. Exception requests to these soft caps or any other caps by a provider will not be accepted. Providers can support the members as the service plan is developed, but they cannot pressure the case manager to authorize hours that are not supported by an assessed need. Providers must sign the service plan signature page, otherwise a PAR cannot be completed. Again, case managers are the ones submitting the exception request, not providers. Providers and employers are responsible for ensuring only authorized tasks and services are provided and bill accordingly. The provider is responsible for recruiting, ensuring adequate staffing, and ensuring each caregiver can provide high quality and safe care. This includes recruiting staff beyond family members. Care coordination is a requirement. Document what other services and providers are in place for your members. Make sure you're following Colorado Department of Public Health and Environment and HCPF regulations on care coordination. With that, I'm going to pause and turn it over to Danny and see if there's any other questions, themes of questions that we want to address before moving on to the next initiative.
Yeah, absolutely. So we are getting quite a few questions about just the exceptions process, specifically about what it's about. And it sounds like there have been some general concerns that they're hearing, that providers are hearing from case managers, that these limits are hard limits and there aren't exceptions. But here we're talking about soft limits. So I think if we can maybe just provide some clarification about, is this actually a soft limit or what should they expect?
Absolutely. So please note that all of this information has been given to case managers as of last week. So perhaps there was some confusion that had been percolating in a case management agency prior to that training. But exceptions processes are where the case manager can ask the department to exceed a cap. So that applies to all of the soft caps, so those annual unit limitations on the service. It applies to some of the exceptions, or it applies to the process to exceed a certain task standards. And then it will apply to, and I'll speak to it under Community Connector. And really what we're looking for is that this is kind of the standard of what can't be exceeded. But if you have an extraordinary need, one that is documented and supported through justification, the department will take a review of that and determine if additional units are appropriate. And so we have an established process that is going to be in regulation and is outlined to our case management agencies on what they need to do and what that criteria looks like and what they need to submit in order for that exception process to be completed.
Thank you. I don't know if we're going to be able to answer this one today, but there were quite a few questions specifically about the legally responsible person homemaker. And I think the general theme is if there can be two legally responsible people that can provide up to 5 hours of homemaker, why can't there be one legally responsible person that provides 10 hours of homemaker? And I don't know if we can speak to that, but
yeah, I think that's a fair point. What we had initially had is a limit of 5, and then we realized that people have often 2 legally responsible persons that can do both of those. We did the same thing when we had the limit of 10. Someone could actually get a limit of a total of 20. So what we're really trying to do is kind of create that threshold. And while it seems a little arbitrary because we're at the end of the day sometimes authorizing 10, but at the end of the day, not everyone has those 2 LRPs to provide that service. All right, Danny, any other themes that we should address today based on these topics? And I do know that there are hand raised. We're going to wait to the end to get through the content.
Yeah, perfect. I think that's the bulk of it, specifically tied to the soft caps.
All right. All right, thank you. All right, so in addition to the 5-hour legally responsible person cap for homemaker on caregivers, there's also an overall cap for caregivers that applies across multiple services. Next slide, please. We're implementing a weekly limit of 56 hours per caregiver for a single member. This limit is for the total hours across personal care, homemaker, health maintenance activities, long-term home health aid, and long-term home health nursing services per member. Please note this does not impact private duty nursing. That is exempt and outside of this 56-hour cap. The 16-hour per day limit for caregivers across all services and members is still remaining in place. A caregiver may work up to 56 hours a week per member. Additionally, each caregiver may work up to those 16 hours per day total for any number of members that they care for. A caregiver may work more than 56 hours per week if they provide care to multiple members, so long as they don't exceed that 56-hour a week per client cap, and then that 16-day total. So the math gets a little wonky, but this means that there is a limit on the number of paid caregiving hours someone can provide each week. This doesn't mean case managers will be reducing a member's authorized hours, though. Case managers will speak with the member about the caregivers they have and make sure that they understand and are aware of these new limits. If the caregivers are above the weekly limit, work will need to be done with you all to identify additional caregivers who can provide that support. If a member needs more than 56 hours per week of services, they need to work with you all to recruit additional caregivers. We've got a couple of options. We have our Direct Care Careers website, the national job platform designed to connect direct care workers with employment opportunities, as well as for self-directing members, information assistance through Consumer Directive Colorado, another free resource. So there is no exception for children or adults to this limit. So this is a hard cap where there is no allowable exception process. In rare acute emergency cases, these caps can be exceeded temporarily, but there's no way to request an exception ahead of time to go over this limit. And you're probably already asking yourself, what does an acute emergency look like? What we're talking about is that a caregiver, there is a sudden snowstorm or they get in a car accident and they're unable to show up for their shift. And if this person doesn't step in and to provide that care, then there's no one available to provide that care to them. Next slide, please. Okay, so what you need to know. Providers and employers must ensure that any approved hours above the caregiver limit are provided by a different caregiver. Provider agencies must support members and families in finding alternative caregivers to provide homemaking services as needed. All right, I know there are lots and lots of feelings and opinions and concerns about this policy. We're not going to be addressing concerns of that policy, but Danny, if there are any questions specific to the caregiver cap, we can answer those now.
Yeah, I think this one's just a really general one, really just to clarify for everybody, but when should providers expect to start instituting the 56-hour limit?
Great question. So when a member has if they have their CSR beginning April 1st through, I believe, September, they will be having their service plan looked at their continued stay review. If not, they'll be doing that at a monitoring event. As I mentioned, everything needs to be done by November, but they will be doing that on a staggered basis, kind of dependent on when their service plan needs to be renewed. Their case manager will be sharing all of that very specific information with the member so that they know when these changes will be impacting.
Thank you. And I think you mentioned this, but just the group wanted a clarification. PDN is exempt from the 56
That is
hours.
correct.
Okay.
PDN will still, a caregiver for PDN, a nurse for PDN would still need to comply with the 16-hour a day limit, but their hours are not included in that 56-hour cap.
Thank you.
All right. Thank you, Danny. All right. A couple more to go. We've got up next is an age limit and caps for Community Connector. Another service that we are talking about is Community Connector. This service is available to children on the Children's Extensive Support and the Children's Habilitative Residential Program waivers, CES and CHIRP. These are highly specific, purpose-driven services intended to support one-to-one community integration for members 6 and older, school-aged children who have an exceptional need that exceeds age-typical parental or legal guardian responsibility. It's a mouthful. This service is provided to a single child who is in need of extra support to connect with, meaningfully and actively participate in, and use community resources. Paid supports for this service is when you are actively providing supports throughout the activity. As I mentioned, it needs to be provided one-on-one. If other children are present during the activity, another parent or responsible person must be present to supervise those other children. The purpose of this service is to support community integration and independent participation, or moving toward independent participation through relationship building, skill development in community settings, and delivered under a person-centered support plan along with other available supports. It's key to remember that in addition to a community connector service being an active part of group activities, the service also requires it to be above and beyond what the responsibility of a parent would normally do. So it helps the member build relationships with people with and without disabilities, develop independent community participation skills, access natural supports and resources to integrate into their residential community, uses the community setting to build relationships and natural supports with unpaid community members without disabilities who are not paid staff or family, and is not intended for brief interactions or passive presence. It's used to develop the skills needed for the member to actively and consistently participate in most age-appropriate community activities. It needs to be developed or delivered on a person-centered support plan with targeted skills or behaviors, measurable goals, defined strategies, and use of all available services to address the exceptional need. Authorization by CMs are provided only when an exceptional need exceeds age-appropriate activities. They're beyond what's ordinarily expected parental or legal guardians to provide as defined in the age-appropriate guidelines. Next slide, please. So the new age limit for Community Connector for this benefit is for school-age children, ages 6 and up, with an assessed exceptional need. For children under the age of 6, accessing and engaging with their community is considered, of typical parental responsibility. The Community Connector age limit will be effective for all members that this applies to beginning April 1st of 2026. So all other initiatives will be done on a staggered basis except this one. This is all happening for these members on April before. Well, it will be effective April 1st. I want to make sure that's clear. There may be service planning that takes place prior to April 1st, but it is not effective until April 1st of 2026. Please note, this is a hard limit. There is no exception process to request services from a member under the age of 6. For children over 6, Community Connector has new limits that will be effective April 1st forward. This will be done on a staggered basis. The unit limit for Community Connector is moving to 1,040 annual units. This is a reduction by half from the previously allowed amount. Please note, though, that the 1,040 annual limit is not something that is automatically allocated for each child to that full amount. It needs to be done and authorized on an assessed exceptional need, clearly documented goals and strategies, appropriate community activities, reasonable units tied to those specific activities. A 6-year-old needing help with safety is typical parenting. A 15-year-old needing significant safety support may represent, and likely would represent, an exceptional need. Age does matter here. For instance, it's normal for an 8-year-old to still require assistance in a community art class to a certain extent, but a 16-year-old needing assistance would be considered above and beyond typical parental responsibility. Community Connector services must be conducted in a variety of settings in which the member interacts with persons with and without disabilities. This is a unit limit that can have an exception. So case managers may request Community Connector units above this limit through the department exceptions process. We may approve additional units on a case-by-case basis when there is a documented and justified need. Next slide, please. Okay, I won't read you this slide, but we wanted to provide some examples of what could be an appropriate one-on-one support for children at different age groups. We want to make sure that they are community activities that are social, sometimes educational in nature. And while we don't, and I want to make sure it's clear that the service does not cover the cost of fees to get into these certain activities. The units for Community Connector are only for the support personnel that are helping the member meaningfully participate in community activities. Next slide, please. Activities provided exclusively for recreational purposes that are passive in their presence in the community is not a benefit of this service. Examples of activities that are excluded include going for a solo or family walk and hike, fishing alone, to the park alone. Again, I'm not going to read you the list, this exhaustive list, but we wanted to provide examples of what would not be allowable. But please note, it's not designated for entertainment purposes. It's not supervision. It cannot substitute other waiver services, specifically personal care, and it absolutely cannot replace parental responsibility. Next slide, please. What you need to know. Claims will be denied for children with this service under the age of 6 after 4/1 of 2026. 1,040 annual unit limits is effective 4/1 of 26 forward on that rolling and staggered basis. Providers are only allowed to bill according to the prior authorization request and service plan. You must follow age-appropriate guidelines. Services must be meaningful in their engagement, not brief, passive, recreational, segregated, or consist of just supervision. No other children under paid support supervision, and this cannot duplicate other services. Okay, I'm going to pause for a moment and turn to my team and see if there are any questions on this specific initiative that we can address.
Yeah, I think we have a couple general questions. First one is I think they're just trying to understand the proration a little bit more. So an example might be if a child already has a full year of Community Connector authorization before April 1st, will their hours be reduced when the 1,040 unit cap takes effect?
Great question. And since they're already at that unit limit, their case manager will work with our team. We have a couple of awesome and dedicated staff who they will submit an exception request to determine how many additional hours can be authorized because they will be over that cap. So the proration process can't really take effect for that particular person if they've already exceeded the units. And so what we are doing is authorizing an incremental amount to get them through to that next service plan. We don't want to cut anyone off from services and say, sorry, you've used all of your units. Wait till your next service plan year.
Thank you. I think there's one more general one that I'm seeing in here. A few slides back, you had a list of examples where Community Connector might be appropriate. And a general theme I saw is, can older children participate in activities listed under the younger age categories and vice versa, as long as it's appropriate, or is that pretty strict?
No, you can definitely go up or lower in age. Those are just some examples of things that could be done. So it could be that an older child absolutely loves to do some of those things that a younger child that we have marked as that, but it is by no means a strict. Those are simply trying to provide some examples because I think the big struggle that we get asked a lot is, okay, if it's not this, then what does Community Connector actually include? And so trying to provide some examples of what appropriate utilization would look like.
Thank you. I think that's the gist of it. Those ones were all pretty on theme.
All right. Well, then let me get to it with our next initiative, our last initiative for today. So there are some changes to the individual residential services and supports benefit. Next slide, please. So the way IRSS settings are defined in regulation is pretty unclear and doesn't account for the variety of settings available to members receiving IRSS. Further, there are 2 rates for IRSS, and it's been confusing which rate each setting should be. Specifically, we don't have clear delineation between post-home family caregiver and then lots of those other settings. We need one consistent type of category or 2 different categories that align with our rate methodology. We're clarifying definitions and regulations and our billing manuals for IRS settings to ensure that host homes, family homes, member homes, staffed homes are all clearly defined and the rates are appropriately aligned to account for the operational and administrative costs for each setting and match the developed rate methodology. Next slide, please. So the definitions for these 2 new categories are a staffed home. It's a setting in which IRSS supports are provided by the residential agency staff who do not serve as the primary caregiver. Care in a staffed home must be managed by the provider agency. Please note though, and we've gotten asked this question, can a family member still be a staff if they don't live there full-time, yes, family can act as a caregiver in a staff setting. The reason that this is at that higher rate is that these are typically agency staffed and cost more to operate. The other category is IRSS shared living environment. This is encompassing, it's a setting where services are provided to the member by an individual who acts as a primary caregiver for the member or members if there's more than one. It can be up to 3. A primary caregiver is a caregiver who personally provides, on average, at least 51% of the IRSS supports to the members and resides in the same residence with the member. The setting must be occupied by the individual providing care a majority of the time, or 75% of the time. A host home is considered a residence type under the IRSS shared living environment setting, same as family caregivers. They are providing effectively the same type of service, often one-to-one in a home environment. This model has lower staffing costs because the caregiver lives in the home. They have similar rate methodology. They are under the same rate methodology. Next slide, please. Provider agencies will be required to perform the following actions for members in IRSS settings. Categorize each member's IRSS setting according to the updated definition, staffed home or a shared living environment. Notify the case manager in writing of any change in the setting type requiring an authorization update, so a change to the PAR. You need to maintain documentation to demonstrate compliance with service delivery records, residency verification for primary paid caregivers, and payroll and/or payment records for staff. Provider agencies must understand that failure to comply may result in recategorization of a setting type, corrective action, or potentially recruitment. Provider agencies will continue to demonstrate compliance with all billing requirements outlined in the regs, the billing manual. Okay, last slide, please. I have thrown a lot of information and content at you. Please note that this recording, this presentation, will all be posted on the department's website along with all of these resources that we have available. There are operational memos for each one of these initiatives talked about. There is memos talking about the utilization of the direct care services calculator, health maintenance activity documentation, all kinds of different things, age-appropriate guidelines. Our staff has created a fantastic community connector service guide specifically for providers, in addition to case management agencies. So we've got a lot of really fantastic resources available. With that said, I know there is got to be lots of questions. I know there are lots of hands raised. And so I will try my best to give as many folks time today to ask their questions. So I ask you to be brief. Again, please keep your comments or questions today specific to this training. This is not an opportunity to relay concerns or issues with the policies themselves. So without further ado, Molly Wiley, I hand it over to you for your turn.
Can you hear me okay?
I can, Molly. Hi.
Oh, great. Thank you. This is Molly Wiley. I'm a family advocate with Aviana. I'm wondering if you can pull apart a little bit the 4/1 effective dates for the soft caps and the 56-hour cap. I know you talked about staggered unrolling, so 4/1 CSRs onward, and it sounds like up to September 1 CSRs, and everyone else will have their changes at a monitoring contact. But what about, I want to ask you about revisions. So for example, if someone has a revision and maybe is requesting hours to a category that hasn't hit the soft cap, will that revision or the request for the revision impact the previously approved hours that may be over the new soft caps? So a revision anytime after 4/1, what does that look like in terms of like previously approved hours being changed?
Molly, that is a detailed and good question. And I believe that it might be a little nuanced. If you're doing a revision we would be asking the case manager to be utilizing the new direct care service calculator. So they would be using it to look at those tasks. However, I don't think we're looking to make any drastic reductions to a member during a revision process. We would be wanting to wait until that uh, monitoring visit or their CSR. I don't think if anyone else wants to pipe in that might have an answer, I don't think we're looking to at a revision time hit someone with the soft caps or the 56-hour cap. Those are really being reserved for the monitoring visit and the CSR.
Okay. And then another scenario would be, I know the direct care services calculator that has the built-in soft caps now and exceptions process. Case managers are to be using that now. So what about for cases that are maybe the waiver was approved a few months ago, they're just getting services set up now? And is the case manager using an older calculator? Should they be using another calculator that doesn't have these soft caps built in?
Yeah, so the soft caps are built in, but they're not being enforced. And that's so that case managers have the tools available to do that service planning process leading up to 401. But we are not enforcing those soft caps, and that's been made very clear to case managers. So while they're using the new direct care service calculator, we are not enforcing those, and we're not looking at them at an exception process. So if they authorize, they might come to us and say, hey, we need an exception. And we say, actually, you don't. Go ahead and proceed with your authorization. We've gotten one of those so far. So it's not being enforced.
Okay, good. And then my last scenario is a waiver to waiver transition. So after 4-1, someone is on, let's say, the EBD waiver, moving over to SLS. They already have like a CFC authorization for all of their direct care. And I know a waiver to waiver transition is a new assessment. Is that a scenario that kicks in the new, so even though they have previously authorized things from their previous waiver at par,
Yeah.
a new waiver assessment equals a new CFC assessment and the new soft caps. Is that right?
You know what? I think yes, Molly. I would ask that perhaps you submit that to the questions inbox because I'd like to get some. We don't have our case management friends on here since this is provider focused. I'd like them to weigh in on that, but I think it likely would because you're starting basically
Brand
over.
new.
Cassie, I'll just chime in. That's correct.
Thank you, Kylie. You are
Yeah.
here.
Molly, you're correct. If you're doing a new enrollment into a new program, you're going to do a new assessment, which is going to include a new DCSC because it's a new waiver plus CFC enrollment, new certification span. You get a new DCSC, new authorization. And if that start date is after 4/1, then that those soft caps are subject. And then the case manager would, if they need to, submit that exceptions process.
Okay, thank you so much. Sorry to hog the mic.
That's all right. All right. I will turn it over to Joelle if you'd like to ask your question. Come off mute and please tell us who you are and who you represent.
Yes, can you guys hear me okay?
Yes.
Awesome. My name's Joelle. I'm a nurse with Circle Care Provider Agency. I have a couple questions. I did throw one in the chat to kind of add to what Molly was talking about. So an example would be we have a family that's wanting to change agencies over to us. And we were under the impression, it would be a transfer part, their hours would be able to follow them. But now the case manager is saying that they have to follow the caps versus waiting until their CSR. Is that one like where you guys wouldn't enforce the hard caps and maybe we can escalate that to you guys?
Yes, you can. If
Okay.
they're just simply transitioning, there's no, again, the caps are not being enforced until
Right.
April 1st. So
Okay.
no, it shouldn't. So if you're seeing an issue there, please escalate that to the HCBS inbox or through the case management escalation form, either one of those routes, and we can take a look in the situation.
Perfect. And then a question on protective oversight. So I know the slide said it can't be like delivered by itself. Does that mean with it needs to have another personal care task, or could it back up to an HMA or a homemaker visit?
Danny, if you don't mind answering that, I would greatly appreciate that.
Yeah, that is a really great question, Joelle. So the intention behind protective oversight is, and the phrasing in the rule is specific to saying protective oversight cannot be the only reason that personal care is authorized. And so if other services are being provided in the home, the protective oversight can be needs to be completed simultaneously. The caregiver can't just be authorized services only for protective oversight. That being said, if they're there for homemaker or HMA, I would say that the protective oversight could be permitted, but keeping in mind that the provider qualifications for HMA providers and personal care providers and homemaker providers are slightly different. So we would just need to make sure that whoever's providing the care is providing it in accordance with um, the benefit requirements for providers.
Got it. Thank you. Yeah, I've heard multiple things from case managers where it's like, no, it can't be approved by itself, and other people say that it can. So I just want to throw that out there that we're getting mixed things back from different agencies. And then my last question, again, kind of adding on to what Molly had. So we've had kiddos get on the waiver. We assessed them back in November. The case manager told us the hours were approved before these caps were in place. But the PARs were created wrong. We're trying to get the PARs updated, like the homemaker lines and things like that, and they're unwilling to backdate, or I guess even adjust the PAR to the correct line, when previously the family had been told it's approved, but we just haven't been able to bill because the modifiers were incorrect. Is that something the state would honor too, like the going back of hours that were previously approved? If that makes sense.
I think so. I don't want to speak to a very specific and nuanced case. If you wouldn't mind emailing that into the inbox, I think if if the case manager is going retroactively back to adjust to some of these caps, like that's not what we have asked case managers necessarily to do. We've done that a little bit in terms of some homemaker for services that were very inappropriately authorized. But generally speaking, we are not asking case managers to go back and say, hey, you did a service planning thing last July, and it feels like maybe some things aren't right, and you need to go back and adjust. Absolutely not. That is not the intention of these changes. What we are asking case managers to do is have this information now and utilize it for those cases that they're planning on and working on to be effective April 1st.
Gotcha. Yeah, because and we have probably like 20 like this. But again, they were previously approved for, let's say, like 12 hours of homemaker LR when it was still the 10-hour each. Now we're trying to get them to revise it because they didn't put everything on the LR line, and now they're coming back and saying, no, it's only 5 per caregiver. So would you recommend we escalate those to you guys as well?
Please.
Okay, perfect. Thank you so much.
All right. Thank you, Joyer. And I apologize to those that have their hand raised and didn't have time today to get to. Please feel free to put your comment in the chat or excuse me, the Q&A. Please fill out the comment form. We are taking these. We want to make sure that as providers, you all have the information you need to be able to operationalize these changes. So if there are things that we are missing, please tell us, and we will absolutely get this information out to you. So thank you very much for joining us today. I really appreciate it. Bearing with me as I talked to you for an hour. So thank you all.